the DNA for methylation, and that is the reason why we have genetics and then epigenetics. Epigenetics is the one which makes many changes which are very constructive and required, and they come only when methylation occurs. And that is the reason why folic acid, where we do not have to look for that MTHFR gene for polymorphism, we can give a well-prepared drug which provides you methyl group in a ready form. But then that provides you methyl group once, and it again goes back, that folic acid again goes back into circulation to remethyl itself and come back into the cycle and provide methylation to the other. So then where did the methyl group comes from? That comes from choline. So we never knew that choline is one product which gives us, which is an additional product which, although present in our nutrition, but if it is deficient, then there is no methylation. Then secondly, that if the patient has an MTHFR gene mutation, she cannot reduce, she cannot take out that methyl group from the folate. So these are two drugs which have come in combination. We have a methyl tetrahydrofolate plus choline, which is a methyl group donor, in a combination so that it doesn't suffer. The pregnancy doesn't suffer. Pregnancy is a situation where there is a high output. We require a new placenta, we require a new baby, we require new vasculogenesis in the mother. And all these are dependent on nutrition. And if they are not there, whatever the diseases, maybe IUGR, maybe eclampsia, maybe preterm labor, maybe small for growth baby, they all will be affected. They all will be there. And if we do not have a methyl group, if we have a patient with MTHFR gene mutation, she will never be able to take out methyl group from the folic acid. So this is the basic idea on what we are talking about. And Dr. Manjupuri, I remember, I think 2 years back, she had taken us through that what happens if we give folic acid unaccounted for, because we are supplementing everyone with folic acid. So where we go through a breakthrough innovation in pregnancy care. So everyone wants a smart kid with a potential for a better future. And we all now know that all the adult diseases, they have an origin in the fetal state. So if the fetal state is compromised, the baby is not only endangered in the pregnancy, but even in the adulthood and adolescence. So what is the importance of nutrients and epigenetics? Nutrient responsive epigenetic mechanism. These are, take care, it is nutrient responsive. They can change gene expression, resulting in modulation of metabolic pathways. Like methyl donor nutrients, which are folate, betaine, and then we have B6, B12, B9, already folate is there, and choline, most important, dietary choline. So methyl donor and some epigenetic mechanism can modify gene expression without modifying the genetic code by methylation of DNA or histones. And this is a very, very important epigenetic mechanism which comes into play, and when the baby is being born, baby is being made by the mother. So although folate supplementation is routinely given as per guidelines, adverse pregnancy outcomes are still relevant. Why? So folic acid deficiency has been associated, I told you, everything would come. Gestational hypertension, preeclampsia, FGR, IUGR, SGA, spontaneous abortion, low birth weight, reduced brain function and motor and somatosensory processing, cleft lip, anemia, and cognitive impairment in offspring. Encephaly, spina bifida, because these are the most sensitive organs which are developing even before the patient comes to. That is the reason why we want supplementation of folic acid in periconceptional time. Problems with maternal erythropoiesis, growth of the uterus, mammary gland. So this is a basic, it's not very clear. It's a folic acid. It undergoes so many changes. Folic acid converts into dihydrofolate, converts into tetrahydrofolate, and there from tetrahydrofolate we have to take a methyl group to make it 5-methylfolate. For that we need an MTHFR reductase enzyme, and that enzyme, if it is active, we can never get get the 5-methyl tetrahydrofolate, which is the active form of folic acid, which acts as a methyl group. So, impact of repeated, and if we keep on giving repeatedly folic acid, this and the patient is deficient in that MTHFR gene. So, there will be methylation of the folic acid to methyl tetrahydrofolate, and that will accumulate. So, one is accumulation of methyl tetrahydrofolate, which is unmetabolized. Second is depletion of methyl pool, which others could have used, but folic acid, because it was present in plenty, it took up everything. So consumption of methyl group leads to deficiency of methyl in methyl pool, and 5-10 tetrahydrofolate cannot be converted, cannot deliver methyl group to DNA, and homocysteine again cannot be metabolized, and there will be accumulation leading to hyperhomocysteinemia and adverse pregnancy outcomes. We've already seen those. So, however, the generation of circulating unmetabolized folic acid has become a matter of concern and may compete severely with the natural active folate transfer. For methyl, we need that methylation is required. So, impact of unmetabolized folic acid is multifold. There could be reduced intestinal folate absorption because the body senses there is enough folic acid, so it would not absorb. And then intracellular intake folate deficiency would be there, reduced active folate would be there, compromised target methyl transfer will be there, consumes methyl from the methyl pools causing methyl deficiency per se, lesser methionine synthesis, defective DNA methylation, leading to reduced methionine and methyl transfer causing hyperhomocysteinemia, and excessive methyl consumption of excessive 5-methyl tetrahydrofolate production is there, and reduced methylation capacity, exaggerated hyperhomocysteinemia. This just a vicious cycle which sets up, and if we have to break that vicious cycle, and we see how can we do that by nutrient supplementation, because natural sources have to undergo through this process. So unmetabolized folic acid will pass from mother to the placenta and from placenta to the fetus, where again it will have its own adverse effect that will be leading to placental hyperhomocysteinemia, placental vasculopathy, which is the reason for hypertension in pregnancy, which is the reason for SGR, IUGR, and fetal growth restriction, endothelial cell damage through atherogenesis, and once it reaches the fetus, it's likely to accumulate in the fetus and cause deficiency in developmental anomalies in the baby, because baby is forming all its organs, and all its organs are in desperate need of methylation, and brain is being developed, all the organs are being developed, so there will be structural anomalies and maybe functional anomalies as well. So we see that on it has been seen on research that high inactive folate is detected whatsoever type of folate we supplement. So they have given 5-methyl tetrahydrofolic acid. Even then we can detect less than 0.2 nanomoles. Folic acid greater than 400 micrograms can be detected, and L5-methyl tetrahydrofolate giving them again we can detect circulating folic acid, which was unmetabolized, and plain again folic. These are different studies. So irrespective of the type of folate dosage and duration, there is accumulation of unmetabolized folate in serum with detrimental effects. So this is again risk of unmetabolized formation from different type of folate. Folic acid, there would be lots and lots. Then L-methyl folate. See the difference between L-methyl folate and water folic acid is the carrier. L-methyl folate has calcium as the carrier, and water folic has glycosamine as the carrier. Although both are 5-methyl tetrahydrofolate active form, but the better bioavailability is with water folic. So this is the basic difference. Folinic acid, we again see it can go into it gives active folates to a higher quantity, and water folic acid is very active and gives you for methyl group for remethylation also active folates, and DNA methylation is well taken care of. Based on dose and demands, DNA methylation of different forms of folate differs. Risk of different forms of folate to form unmetabolized folic acid differs. Obviously, it will differ For quadrifolic, DNA methylation is the best and unmetabolized formation is the least because we are giving in the prepared form. So this is again another diagrammatic representation. The quadrifolic acid, which is a glucosamine salt, of 6s5-methyl tetrahydrofolate, has the least risk of unmetabolized folic acid formation and best target methylation because it is reaching the target. So this is another study which says there has been enhanced oral bioavailability of quadrifolic, which is better than L-methylfolate and folic acid also. We are comparing it with L-methyl. There are so many L-methyl tetrahydrofolate available. So we have seen the quadrifolic has got the C maximum is 879.6 versus 486.8 with L-methylfolate. And the maximum peak is reached in 1 hour for both of them. And area under curve would be 1100 for quadrifolic and 997, that is nearly 1000. So we see quadrifolic scores faster, better because it has got a better water solubility. So in pharmacokinetics, bioavailability, stability, and solubility are measured by quantifying area under curve, Cmax. Quadrifolic supplementation shows better AUC and Cmax values than the calcium salt, which is L-methylfolate. So over here in this bar chart, we can see quadrifolic is leading, and after that comes L-methylfolate, and then comes the folic acid. So again, this is another chart which shows the same maximum absorption of quadrifolic is associated with better water solubility, maximum area under curve at 8 hours, and 9.7 times higher than folic acid, and 1.12 times higher than calcium. L-active form we are using. Unutilized folate is the least with quadrifolic acid. So quadrifolic acid is the glucosamine salt of methyl tetrahydrofolate and is structurally analogous to the reduced and active form of folic acid. So quadrifolic acid completely bypasses the damaged MTHFR conversion step and delivers a finished folate. The body can immediately use without any kind of metabolization. And so is with L-methylfolate also. But it is a, take care, it is a calcium salt. So this is another, this is the diagrammatic representation. The folic acid has to undergo so many steps, and quadrifolic is giving you ready-made 5-methylfolate. So this is L-methylfolate versus folic acid. As I said, L-methylfolate also it is an active form. It also gives you 5-tetra-methylfolate in an active form, but it is a calcium salt where the solubility is less and bioavailability is comparatively lesser than quadrifolic acid. So quadrifolic and homocystinemia, if the availability is there, this has been a randomized controlled trial effective of different sources of folic acid and B6 and B12 supplementation in normalization. Objective was to investigate the efficacy of quadrifolic in lowering hyperhomocysteine levels in hypertensive subjects, and the results showed that ideal hypercysteine levels less than 10 micromoles per liter was reached in nearly half, more than half, 55.8% patients in the quadrifolic group and was significantly higher than the control group. The treatment is safe, well tolerated, and effective to reduce the hyperhomocysteine level. So now this is the story of the quadrifolic acid. Now we have given methyl tetrahydrofolate. It has gone into the blood. It has supplied the methyl. It is now in the reduced form. It can be recirculated again and become and enter the folic acid cycle I had shown you, but it needs methyl group for it. Where does it come from? So 450 milligrams of choline supplementation across 3 trimesters of pregnancy is very important. Choline modulates methylation via beta homocysteine methyltransferase enzyme and regulates concentration of S-adenosyl homocysteine and S-adenosyl methionine. So methyl donor choline and other nutrients have an important role in preventing developmental anomalies and preventing origin of chronic diseases like many cancers. Over here it's just written liver cancer, even stomach cancer, pancreatic cancer, and then ovarian cancer, breast cancer, everything is being taken care of. Secondly, choline is a part and parcel of so many other structures in the body. It comes as phosphatidylcholine. That's a product of a metabolite of choline, which is a part of the cell wall structure. So very important to maintain the integrity of the cell wall. We need phosphatidylcholine. That's why we need choline. That is additional indicator. Again, in the brain, for the brain neural development, again we need choline to form the covering of the neurons. And acetylcholine, we all are very familiar. That's another chemical which is very much required by the body. So choline plays many roles besides being a methyl donor. So contribution of methyl and homocysteine neutralization. Quaternolic is giving you folate cycle pathway, but choline converts into betaine, converts into dimethyl glycine, into sarcosine, and it thus provides three methyl molecules for the homocysteine pathway, where it can be converted into glutathione by transsulfuration, and it can be converted into methionine by remethylation pathway of folic acid. With B12, choline metabolism pathway and demethylation pathway, it again converts into homocysteine. So this is a very balanced reaction going on in the body, converting folate into tetrahydromethyl folates, using using homocysteine for its own metabolic processes. But wherever it is deficient, we will see the backlog. Maybe we see the backlog of unmetabolized folic acid. Maybe we see the backlog of homocysteine, which all have got a detrimental effect on the development of the baby. So parallel pathways, choline offers 3 times more methyl groups than other methyl donors, ensures folate-mediated methyl transfer and neutralization of homocysteine, meets the increased demand of methyl transfer during pregnancy. So these are the parallel and complementary pathways. 3 of them, folic acid is being converted into 5-methyl tetrahydrofolate in a folate cycle. In methionine cycle, homocysteine is being converted into methionine by utilizing again methyl groups, and methyl group comes either from the folic acid or comes from the choline, and which is giving us 3 methyl molecules, and it is converted into dimethyl glycine in the choline cycle. So essential processes of this is required, as I said, choline is required for membrane biosynthesis and tissue expansion, neurotransmission and brain development, methyl group donation and gene expression. As I explained, how the genes are being modified by modifying the epigenetics. So conclusion from human studies says that improved several pregnancy outcomes have been seen and protects against certain neural and metabolic insults. So choline is a critical role during fetal development and dietary requirements. It is required for structural integrity and signaling functions of the cell membranes, cholinergic neurotransmission, that is acetylcholine, muscle function, lipid transport. So in conclusion, it is essential for fetal development, influences stem cell proliferation and apoptosis, essential for brain and spinal cord structure and function, thus reducing NTDs, improves lifelong memory function. So that we have brighter and smarter kids. So association between maternal choline, fetal brain development and child neurocognition was done in a study. Low choline intakes were associated with higher risk for NTDs, and higher choline intake was associated with better child neurocognition and neurodevelopment. So in conclusion, the result should be used to as guide the choline intake. All the choline is present in our diet, but if we supplement it, maybe that choline is not available, maybe there is malabsorption, maybe it is deficient, because pregnancy is a situation where you need everything in multiples. So that is the time maybe choline deficiency occurs, and if we supplement choline at that time in a nutrient form, we will get a better outcome as a fetal development. So prenatal folate and choline levels and brain and cognitive development in children is being well documented, that if choline and folate are given to pregnant women, it reaches the baby, it's responsible for DNA methylation, alter gene expression. It is not changing the genetic code, it is just altering the gene expression by epigenetic mechanism. And it reaches the brain, it can cause cellular proliferation, neurogenesis, reduce apoptosis, timing and differentiation of neuronal progenitor cells. And if it is absent, there will be altered neural function, altered acetylcholine release, and altered neural pathway. So cognitive outcomes, if we need a better cognitive outcome, we have to supplement the 2 nutrients together so that the baby can have a better attention, better learning, and better memory. So choline risk and neural true defects have been studied again in folate fortified population. NTDs continue to occur despite supplementation. With plain folic acid, low levels of choline are a risk factor and higher levels are protective for NTDs. Adequate choline supplementation reduces the risk of NTDs by ensuring optimal DNA replication. Aids cell membrane synthesis, neutralizes excess homocysteine, helps in neural tube closures, and supports early embryogenesis. So these are the problems we all can understand. Why do they occur now? The mother would be exposed to preeclampsia, pregnancy-induced hypertension, trophoblastic invasion would be altered, postnatal depression can be there, gestational diabetes mellitus, preterm birth, bleeding complications, angiogenesis, and cancers, and maternal death can also occur because of the secondary complications. Placental could be placental abruption, insufficiency, abnormal growth, placental growth, placenta creta, ingreta percreta, chorioangiogenesis, venous thromboembolism, distal villus hypoplasia, circumvallate placenta, because this is a thing which every tissue which is rapidly multiplying needs and in sufficient quantities. If it is deficient in any stage, we can get any type of abnormalities. The baby, we can have neural tube defects, spina bifida, electrically, oral facial clefts, omphalocele, fetal growth retardation, autism, congenital heart defects, vision-based defects, and cognitive dissonance, teratogenesis, and peripheral neuropathy, low birth weight, and muscular dystrophies. That's a lot. If we can prevent by simply giving nutrient supplementation, we are not giving medication to the mother. So pregnancy is a natural homocysteine generator. In pregnancy there is high utilization of folate. Utilization of folate will naturally produce high homocysteine levels. So pregnancy potentially is a hyperhomocysteinemic state and it can cause consequences to mother, placenta, and fetus if that homocysteine level is not being taken care of. This becomes higher if there is deficiency of the methyl group. So again, hyperhomocysteinemia will give you nearly the same sort of disorders which we have just enumerated. So choline and quadrifolic are complementary in hyperhomocysteinemia of pregnancy. Choline deficiency in hyperhomocysteinemic conditions superimpose on each other and many conditions are common. Therefore, folate deficiency supplement with quadrifolic along with choline will ensure better pregnancy outcomes. So why we need choline in first trimester? Significantly reduces NTDs. In second trimester, it reduces the risk of vascular thrombosis, FGR, small for growth babies, PIH, and preeclampsia. And in the third trimester, ensures optimal fetal growth, fetal brain development, and cognitive outcomes. So these are the other benefits. We have just talked about the methyl benefits. These are the other benefits of choline. If there is maternal choline intake, there would be better membrane phospholipids, lipid metabolism, neurotransmission, and methylation, which affects the placental function. And sees to it that the placenta has a better angiogenesis, cellular growth and proliferation, macronutrient transport, and anti-inflammatory properties, which will all depend in placenta having sufficient vessels. And then epigenetic programming, we have already seen neonatal stress reactivity, fetal growth, brain development, and chronic diseases will be decreased if we give maternal choline. And neurodevelopment is also improved. There will be processing of speed, visual, spatial, memory, attention, and self-regulation, and visual acuity. So we come back to the first slide. We want better and smarter kids. Not only healthy kids, now we want better and smarter kids. Thank you.